Hello, my name is Olivia Orlando, and today we are going to discuss the adverse effects of cannabis use. In the world, there are 277 million people who have used cannabis at some point. Increased access to cannabis has been observed since the 2016 elections, when 26 states and Washington, D.C. legalized cannabis in some form, resulting in an increase of cannabis-related adverse effects. While some medical conditions have shown benefits from cannabis use, such as chemotherapy-induced nausea and vomiting and chronic pain, there is also a risk of negative outcomes of cannabis use, including cannabis use disorder, or CUD, cannabinoid hyperemesis syndrome, or CHS, and exacerbation of certain mental health disorders. It is important for us as providers to have an understanding of these outcomes due to the increasing prevalence among our patients. To start, we'll do a case study. Your patient is a 25-year-old male who presents to the emergency room for evaluation of intractable nausea and vomiting, along with abdominal pain for the past 14 days. He has not been able to tolerate anything by mouth other than small sips of water. Upon questioning, the patient has a past medical history significant for generalized anxiety disorder, which was diagnosed at 15 years old. He reports worsening of his anxiety symptoms over the past 2 weeks due to missing so many days of work. The patient has been using marijuana as a way to improve his anxiety consistently for the past 10 years. He reports daily use up to 3 times per day. What is your initial impression about this patient? So with any abdominal pain complaint, you must rule out emergencies such as appendicitis, bowel obstruction, sepsis, etc. Therefore, in an ER setting, a full workup is usually indicated, including blood work, urinalysis, and imaging. With the exception of possible dehydration or electrolyte abnormalities, this patient's results were all normal. You've given him nausea medicine and still no improvement. What do you do next? You should revert back to your history. This patient is a chronic marijuana user, and he is experiencing cannabinoid hyperemesis syndrome. While not often in your typical differential list, you should always consider CHS in a young patient with unexplained nausea and vomiting and a history of marijuana use. So what is cannabinoid hyperemesis syndrome? It usually will present with intractable nausea and vomiting, generalized abdominal pain, and patients will also sometimes report compulsive hot baths and showers. This is a key finding. If a patient tells you this, you should really think about CHS on your differential. To diagnose it, you have to rule out other potential causes, and the patient has to have a history of regular cannabis use. The vomiting will occur in a cyclical pattern, and the only resolution of symptoms, the only way that symptoms will resolve is if they stop cannabis altogether. So CHS is often missed in workups if a drug screen or a thorough history isn't obtained. There are several proposed ways to diagnose CHS, but it is often a diagnosis of exclusion if the patient has an extensive history of cannabis use. To treat CHS, the first line would be trying antiemetic medications such as Zofran or Phenergan. Most patients report relief of symptoms with a dose of haloperidol in an ER setting. Patients may also find relief with topical capsaicin cream that can also be prescribed to them. But ultimately, the only way that CHS will resolve is with the abstinence of cannabis use. CUD, or cannabis use disorder, is another diagnosis that can be made with patients who are chronic cannabis users. This can be diagnosed with using the DSM-5 criteria, which may include large amount of cannabis use over a long period than was intended, feelings of desire to use cannabis, recurrent use resulting in failure to fulfill major obligations, continued use despite social or interpersonal problems, or characteristic withdrawal syndrome for the substance. To put it plainly, cannabis use disorder is an addiction to marijuana. It's a psychiatric disorder that is listed in the DSM-5 and uses this criteria to make a diagnosis. It is important to note, though, that individuals with a pre-existing substance use disorder, mental health disorder, or personality disorder are more prone to developing CUD than healthy individuals. How do you treat CUD? Well, you can try, there are various different types of therapies that have been shown to be beneficial, such as CBT, MET, and CM. Patients who are diagnosed with CUD often have a difficult time abstaining from cannabis. While many individuals report using cannabis for improving sleep and stress, they are reluctant to abstain in fear of their problems returning or worsening. This leads to delayed diagnosis, treatment compliance, and long-term effects. So, some individuals' treatment for CUD or CHS may be complicated by the development of cannabis withdrawal syndrome. These symptoms may include weakness, sweating, restlessness, dysphoria, sleeping problems, anxiety, and food cravings. As a result of these negative symptoms, patients have a high recurrence of relapse to cannabis use. A referral to a substance abuse expert may be required if this occurs. And cannabis withdrawal syndrome is often seen on day 2 of abstinence, which usually resolves around 4 weeks. And here are my references for my presentation. Thank you.